is the growth hormone and the IGF-1 axis. The GHRH is produced via the hypothalamus, which then regulates via the GHRH receptor the production of growth hormone. Growth hormone secretion is also controlled or modulated by other factors like somatostatin, and then this growth hormone is also produced along with growth hormone binding protein. It then circulates with the growth hormone binding protein to reach its target receptor. What is unique about this growth hormone binding protein? What exactly is the growth hormone binding protein?
The extracellular domain of the protein.
Yes.
And what it does, it maintains the growth hormone level in the body. And there is less variability in the...
Is it just a binding protein or does it do beyond that? Yes. So, yeah, binding protein is there for transport, but it is a targeted transport. You can talk it like a chaperone. So, once it binds, it will take the growth hormone to the site of action. And what else it will do? Will the half-life of growth hormone increase? So, in conditions where you have got increased amount of growth hormone and growth hormone binding protein, your half-life will be more. You will have more effect of growth hormone. While if GHBP level is low, your effect of growth hormone will be of shorter duration and the direction will be less. So theoretically, if you treat somebody with growth hormone alone versus GH plus GHBP3, the GHBP1 will do better. But there are not much studies because it's not very easy to do in that regard. So it's not just a simple binding protein, it is also a carrier. And this is unique. So which hormones usually have a binding protein? So peptides have, not the steroids. So steroids, peptides don't need. Peptides basically, will they travel in blood easily or not? So they don't really need a binding protein. So when you have IGF-BP3 or you have GHBP, these are strange, unique things. PTH doesn't have a this thing, FSH, LH, none of them. So it's basically cortisol binding globulin, thyroxine binding globulin, or whatever, it's mainly steroids. So there are two unique hormones, peptide hormones, which have a binding protein, the growth hormone binding protein and the IGF binding protein. Their action is more to modulate the action and guide their action. IGF-BP3 will not let IGF-1 levels to go really up. So if your free IGF-1 goes really up, you may have risk of malignancy. So that's why it sequestrates it for a certain scenario. So now it acts on the liver to produce two important compounds, IGF-1, IGF-BP, and also acid labile substrate, which is ALS, and all three of them will travel in the circulation. And this IGF-BP is now, as I said, is another peptide binding protein, which then carries it to its site of action. The most important site there would be the growth plate, where it will act on the IGF-1 receptor to cause induction of growth, largely the sulfation of the chondroitin. So earlier studies were all about how fast in this chondrocyte the chondroitin is sulfated. That's why this factor of sulfation factor came in. Then people found that this also causes hypoglycemia. And that's why they realized that it acts on the insulin receptor, and that's why it was called as insulin-like growth factor. So growth hormone is basically a large peptide hormone. We know that hypothalamic hormones are small. They will have 3 peptides like TRH, 9 peptide like pretty much like AVP, 10 peptides like GnRH, but there are large peptides. So you can see that there's a huge number of chain of approximately 190 amino acids. It's a single chain. So it's not like insulin where you have A and B chain. It's a single chain. There may be some disulfide bonds which are there as far as growth hormone is concerned. So it's a single chain 191 amino acid peptide which is non-glycosylated. When we talk about non-glycosylated, it means that the post-translational modification is not significant. Compounds which are glycosylated and sialated, what happens to their half-life? So typical example is which peptide hormones undergo a lot of post-translational modification? PTH and very similar hormones. Anything else? Yeah, TSH, LH, FSH, and HCG. So HCG is the most sialated. It has the longest half-life. And that concept is actually used in one of the newer, longer acting growth hormones. So what they do is that they add a moiety of HCG within that particular frame to allow its time period to go off to make it long acting. That's a somatogron from Pfizer is acting based upon that principle. So we'll discuss about that a bit later. There is a disulfide bond. Now there are similar hormones like growth hormone like prolactin. Prolactin is also structurally very similar. You have got human chorionic somatotropin and HGHV, which is again placental origin. And very importantly, growth hormone comes in multiple forms. So circulatory 75% is 22 kilodalton, which is the major functional form of growth hormone. You also have a truncated version in which your amino acids go less, it is 10%. Now, problem is that if you measure a particular epitope of growth hormone, you may not differentiate between the 22 kilodalton versus 20, and you may overestimate the amount of growth hormone. So the recent, or now not that recent, Pediatric Endocrine Society guidelines of approximately 2015 do talk about standardization and harmonization of growth hormone assays, so that you're looking mainly at the active 22 kilodalton, and therefore the levels may become lower when you actually do that sort of a correction in that regard. So these variants are present. Now, somatotropes are present predominantly in the exposed area of the anterior pituitary. You can see on the sides. So that's why they are the most prone to whatever damage happens, be it vascular, be it infection, be it trauma, be it radiation or surgery. So it is extremely unlikely that somebody has a MPHD and doesn't have a growth hormone deficiency. This you can pretty much assume that there would be a growth hormone deficiency in the setting. And that is why individuals with CNS insult-induced MPHD, you don't need to worry much about growth hormone testing. If their IGF-1 is low, you are clear that there is a growth hormone deficiency, because they will anyway have a very high pre-test probability of growth hormone deficiency. They also are very radiosensitive. So it's the first hormone to go in terms of radiation. Which is the most radio-resistant hormone? ABP, and then prolactin will be there. After growth hormone, which is the second one which gets stimulated? ACTH is variable, not essentially in that regard. So TSH will also take, so it's not periphery because radiation is different. This is trauma. So you will have gonadotropin around 30 grays, ACTH around 24 to 30 grays, TSH is high. So that becomes more resistant from that perspective. Now, this we have discussed a lot when we discussed about pituitary, about the control. So we would not go much in that. Basically, what we need to understand is that we can have growth hormone deficiency as part of right at the initial spectrum. So if you have a craniofacial developmental issue like SOX or HESX1 or LHX3 PTX1, you will have a craniofacial abnormalities, ear abnormalities, eye abnormalities, neck abnormalities, and both anterior and posterior pituitary deficiencies. If you have a PROP1 defect, you are mainly talking about growth hormone, cortisol, gonadotropin variable deficiency, and POW1F1 is mainly talking about growth hormone, prolactin, and TSH as a major problem. And then, of course, you can have a problem within the growth hormone gene, which we'll discuss in much more detail, the various types of growth hormone deficiency, which are both autosomal recessive, autosomal dominant, and X-linked forms, which are there because of the GH1 gene defect, which happens in that regards. Now to go back to GHRH, which is a hypothalamic peptide, it acts typically via the G protein coupled receptor through the cyclic AMP pathway. Now GHRH levels, how good are they markers of these disorders? They will be eliminated in the circulation very quickly. So the only theoretical role of GHRH is more in terms of testing. People used to do a GHRH stimulation test like ACTH test, something like that. But again, this is not something which is done very, very often. It has no therapeutic role because it's got a very, very short half-life. So GHRH is working through GH. But do you think it has got its own independent effects also? And how will you know that the problem that GHRH has a GH independent effect? So what I'm saying is that you've got GHRH receptor, growth hormone receptor, IGF-1, IGF receptor. Now, if you say everything goes linearly, then IGF-1 is mediating the growth from everybody. So what I'm trying to ask is there a difference in the phenotype of somebody who has got a GHRH problem receptor problem versus a growth hormone problem versus a growth hormone receptor problem.
If there is an issue at the level of somatotroph, then that is the most severe form. GHRS deficiency will have a slightly milder form because GH production may be slightly independent of GHRS.
Are there any unique features? So GHRS receptor have, Vibha?
We don't have micropenis, we don't have.
So this is a very unique characteristic that the micropenis and hypoglycemia are less likely with GHRH receptor. So which means that there are growth hormone independent effects of GHRH as there are IGF-1 independent effects of growth hormone receptor. So when you say simply that, okay, growth hormone, GHRH causes growth hormone, causes IGF-1, causes growth, it's not, the linear relationship is not true. GHRH is also doing something beyond growth hormone. Growth hormone is also doing something beyond the growth hormone receptor and IGF-1. So this is something important to understand. But from a therapeutic perspective, we are not really looking at in terms of a major role as far as GHRH is concerned. Now, one of the major regulators of growth hormone, which has been used now in diagnostic perspective, is ghrelin. So ghrelin is produced in response to hunger. What would you do if you are hungry in terms of hormonal profile? What do you want body to do? So you want to burn more energy. You want to conserve energy. You want to conserve energy. You want to get metabolites to burn, get you glucose. So you will try to do something to increase your glucose. And of course, you will do something to eat. You want the brain to start eating. So in situations when you're not eating, the ghrelin, based upon the distension of the abdomen, is secreted. It's a 20 amino acid peptide secreted by stomach and duodenum. It goes right to the pituitary, acting via the growth hormone secretagogue receptor to activate growth hormone and ACTH. Which means that if you are hungry, you are producing more growth hormone, but this growth hormone is not causing growth. If it causes growth, then the purpose is defeated. This growth hormone is basically doing lipolysis. And this lipolysis is getting you energy from burning the fat. People with chronic undernutrition who are always hungry will lose all their fat, even the buccal pad of fat. So you will see that that's the last thing to go. And this is contributed via the growth hormone. ACTH, of course, will increase cortisol. It will give you gluconeogenesis and other factors which are there from that regards. It will also go to the ventromedial hypothalamus to increase the appetite. So you will start eating, the orexogenic pathway will get activated. And finally, it will say, okay, we don't have any food, don't waste your energy. So your BMR will come down. It's not the other way around, so BMR will come down. Which hormone has nearly the opposite effect of ghrelin? Not exactly, but nearly. Insulin will increase what? No, in terms of these aspects, if you talk about. So insulin will maybe increase appetite further. So there's a very important hormone which acts, which is peripheral in production, works like that. Opposite to it. So think of it. Yes. So leptin is there when your energy is very high. It is going to say, okay, I don't want you to eat. So anorexic pathway will go up. The energy expenditure will go down. What will happen to growth hormone if you have too much leptin? There will be decrease in growth hormone. So if you think of it, ghrelin and leptin are in a way opposite to each other. Stimulus are opposite, effects are also opposite in that regards. Now, growth hormone regulation I talked about, you see that growth hormone basically is regulated on one hand via stimulatory factor, which is the growth hormone releasing hormone. And this is also regulated via the inhibitory pathway, which is the somatostatin. Which of these is more important, GHRH or somatostatin? In the sense that, is it continuously, which one is working continuously? So what do you want? When you talk about, if you talk about very simple way, you say, when you talk about various enzymes or genes which are working, there are two types of genes. One is which are inducible and one which are repressible. Inducible means that they are resting, when you need, they will be produced. Repressible means they are always active, and then when you don't want, you will basically want them to be suppressed. So what example would you think growth hormone belongs to which category? Do you want growth hormone to be there continuously?
No, not continuously because
Then you're wasting your, when you're, it will be on, so it's like an inducible agent. So for an inducible agent, what is more important? You want to have a repression which is there actively. So somatostatin will decide the tone. That becomes very, very important from that perspective. So growth hormone release is stimulated via ghrelin. As I said, it is inhibited via somatostatin. So somatostatin, even if you have growth hormone, it will not allow it to go off. Once your somatostatin dips down, your growth hormone levels will go up in that regards. Now, GHRH, of course, and ghrelin, they will have an impact. Thyroxine is an important regulator of growth hormone release, as are the estrogen, which is regulating the growth, as well as the cortisol. So you need to have a normal thyroid, normal amount of cortisol, and pubertal status to have a good growth hormone response. So when you talk about growth hormone stimulation test, you said that it should be euthyroid, it should be excluding Cushing syndrome, and if required, do a priming. So these three hormones have a crosstalk which happens in that regards. Now, whether the effect of testosterone is mediated via the aromatization of estrogen or conversion to DHT is an issue of debate, but most people say that the major effect is via this aromatase pathway which regulates this in that regards. Cortisol, of course, is an inhibitory factor as far as growth is concerned. And then, of course, IGF-1 will cause itself a feedback inhibition. If your IGF-1 is more, IGF-1 will suppress the growth hormone production in that regards. The physiological stimuli of growth hormone are sleep. And if somebody is not sleeping well, you will have problems in terms of growth hormone secretion. Which phases of sleep does a child produce growth hormone? REM or NREM? So it's basically the later stage. So you need to be in deep sleep. If somebody is watching a lot of mobiles, a lot of doing other activities at night, and they're not going to deep sleep, you will not be producing growth hormone. Now imagine, when would body like to produce growth hormone? When you are completely fed, when you're completely relaxed, there is no stress. So what better indicator of that will be when you go into a deep sleep? So if you are in superficial sleep, body will say, okay, this person is not in a very good state to grow. It will wait till the time they go into a deep sleep. And in these deep sleeps, you will see a lot of growth hormone response. So many of the children who are now having these issues in terms of responsiveness, if they are waking up late, their growth hormone is not going up. Their cortisol is going up at that time and it should be zero. So if you look at it, midnight is the lowest cortisol. And there you have the highest growth hormone. So that's the best time as far as growth is concerned. But if you reverse that, you will have a growth suppression which may happen. That's why sleep becomes important. Stress also produces growth hormone. Exercise also produces growth hormone. And of course, we know that hypoglycemia is the stimulus for growth hormone. So we all discussed that growth hormone is a pulsatile nature, and this pulsatility represents the balance between the effect of somatostatin on one hand and GHRH on the other hand. So you have got situations wherein you have got a high GHRH and a low somatostatin. You will have a pulse, and then when your somatostatin will come up, your levels will go down. So you will have a pulsatile pattern of growth hormone production which happens. And these pulses, as we've discussed already, typically happen in slow wave sleep, the non-rapid eye movement sleep, stage 3-4. So deep sleep is what is required. There are not too many pulses, 10 to 12 times a day. So that's why everybody gets a basal growth hormone, just like today the patient came with a low level and they will say it's GHD. It is of no use to assess growth hormone stimulation. Boys have a higher level of pulsatility, while the basal levels are higher in girls. Why do you think this is happening? Why do girls have a higher basal level? So we talked about various hormones which are regulating. We talked about thyroid, we talked about cortisol and estrogen. So is the estrogen level in a prepubertal girl higher than that of a prepubertal boy? So even though it is very low, it is still 3 times more. So that is why they have more advanced bone age. That is why they have got more higher basal growth hormone levels. But these, of course, will overlap. You can't say that, okay, this is going to be an issue on that. Now, in obesity, these pulses are blunted. You will have lesser growth hormone rise. If somebody is fasting, your pulses are increased. So when we say, okay, you can do growth hormone testing anytime, that is fine. But if you do at a fasting stage, your pulses are expected to be more. So the false positivity of a growth hormone stimulation test will become less. So despite fasting and the clonidine, he is not producing growth hormone. It means that he is more likely to be definitely deficient in that regards. Now, growth hormone does have a age-related factors. We all know that growth hormone levels are high at birth and then they fall down. And then they rise again because of lack of inhibition, which is there. The levels in childhood are stable and then there is a sudden surge which happens in puberty. This again happens because of estrogen. It's going to go peak it on and then there is a fall and then there is a somatopause which happens. So low levels in the fetal period, sudden rise at birth because of the lack of inhibition, and then you have got a phase where growth hormone is acting at causing growth, peak levels in puberty. That's why people talk about a higher dose in puberty, although there is no recommendation. But some people, if somebody is short, go up to 50 microgram per kg per day also during puberty. Then there is a phase where growth hormone plays a role in skeletal development till around 25 years of age. Then the 25 microgram per kg per day is an appropriate dose. And finally, in the later phase, its major effect is on the adipose side. So if you talk about adult GHD, you're treating mainly in terms of their quality of life, in terms of their cardiovascular risk. And then, of course, there is a somatopause. Now, growth hormone IGF-1, we already discussed. This IGF-1 will bind to the IGF-1 receptor. Or it will be more precise to say a type 1 IGF receptor. Why I am saying type 1 IGF receptor is that IGF-1, insulin, and a bit of IGF-2 also binds to that receptor. And binding to that receptor, it will cause increased growth. Growth hormone, however, will also have multiple other effects. It's going to act on the adipose side to cause lipolysis. That's why individuals who have growth hormone deficiency look plump. They have central obesity, they have got round faces and all the other features of fatty excess. It also has an effect on the kidney. What are the major effects of growth hormone on the kidneys? What do you need for growth? And what grows when you're growing? When you're growing, you need what? You're saying bone is growing, so you need what? And phosphorus. So calcium also, if you really look into that, growth hormone, prolactin and estrogen increase the calcium absorption from the gut. But in the kidneys, growth hormone has a very specific effect of increasing phosphorus absorption. That is why people have used growth hormone in hypophosphatemic rickets, not only to increase growth, but also to increase phosphorus retention. So it's going to cause effect on phosphorus. It's going to have a direct effect on the bone as well, which is independent of the IGF-1. And it is going to affect the liver also to have an effect in terms of glucose levels will go up. So you will have hyperglycemia. So when you talk about treatment with IGF-1 versus treatment with growth hormone, which one will be better? Why?
Pathway of IGF-1, apart from this, there is also a pathway that is directly acting on the...
So growth hormone is having many other effects. It's also increasing IGF-BP. So because of IGF-BP, your free IGF-1 will not go up. Half-life will go up, so the effect will be more. Second, this is causing hyperglycemia. IGF-1 will cause hypoglycemia, which becomes important. Plus, there is also a paracrine effect on the bone as well. So whenever you have got a growth problem and you have option of treating with growth hormone or IGF-1, growth hormone is the treatment of choice. The only indication for IGF-1 treatment is if you have GHD type 1A, wherein you have got antibodies which have developed against growth hormone, which is not working. And second, of course, is genetically proven growth hormone insensitivity. That's the only role of IGF-1. People used to say that IGF-1 would be a better agent. So why don't you use the distal agent rather than growth hormone? But now growth hormone has been found to be more versatile in terms of action which is there. So as I said, growth hormone will have an effect on IGF-1 and this IGF-1 will cause hypoglycemia.